Hi, I'm Naomi Murphy, and this is the Locked Up Living podcast, where we talk with a wide range of people about harsh aspects of institutional life.
We also explore some of the ways to overcome them and to grow and develop. I'm David Jones. So join us every Wednesday morning, 6 o'clock UK time, for a fresh podcast. Dr. Rachel Gibbons is consultant psychiatrist, psychoanalyst and group analyst, and she's been working on understanding suicide and its implications. So we're really pleased to have you on again, Rachel, and today we're going to focus on dying and to some extent the assisted dying bill and any other challenging things that you're working on at the moment.
Okay, well, it's nice to be here again.
Most people probably do know what the assisted dying bill is, but I don't know whether you just want to give us a quick summary at the start, just for anyone who might not have been watching the news, because a lot of people have been turning off the news lately with all the world events.
Yeah, I certainly have, actually. I think there's a lot to be said for not listening to the news, actually. Yes. So, well, I think there's two different levels to this. One is this is I think a worldwide movement. There's a sort of global movement, I think, going on at the moment towards assisted dying, whatever that means. And I think there's something around terminology that's very important here. I'm going to call it assisted dying. And I think there's something maybe we should discuss about terminology, because in different countries it's called different things, including assisted suicide, euthanasia, medical assistance in dying. You know, they're all different. There are different terms used in different countries. But really what we're talking about is a global, what seems to be, a global move towards this concept, which I'm going to call assisted dying. And so in other countries are further on than us. So, for example, Switzerland, has had this, whatever this we're considering this to be, since about the 90s. And it's in the last sort of 20 years that other countries have started to come in, with the Netherlands, and more recently, Canada, 2016, very important to consider what's happened in Canada, and then more European countries. So it feels like it's something that many, many countries are thinking about bringing in, engaging with the concept. Now, in the UK, we've got two bills going through, a bit in parallel, one in Scotland and one in England. And Scotland is a little bit ahead, if you like, of the England, but we're talking not very far ahead, a little bit ahead. And they're going through Parliament at the moment. So for us in the UK to start thinking about this concept of assisted dying. So you've got one in Scotland and one coming through in England. And I think today, Friday the 20th, we're recording this, and this has just got through the third stage of the bill. Just heard that it has now in England. It got through in Scotland, but there's still a lot of other stages to go through.
Why do you think why do you such a pressure for this across the globe now?
I think that's a very important question. And I don't think there's any easy answers around it. But what my thoughts are is I wonder whether we're all starting to think about death. I think we've all maybe avoided thinking about death. We've all been annulled. If I think about it from the medical profession perspective, I think there's a way the medical profession have tried very hard to not think about death and to not think about our job as something to do accompanying people in death, even though that is actually what a lot of our work is. But it's about saving life. And I mean, even to the most extreme situations sometimes of real interventions in people who are very, elderly, unwell, really against their best interests. So there's something I think about, I'm going to reflect it from the medical profession perspective, but I think maybe it's a more global issue, which is us all starting to think about death and what death means to us. What does an ending mean? Maybe we're all becoming more cognizant, if you like, of actually thinking about the end of our life and actually what sort of ending we want in our lives. And also maybe, there's something to do with family relationships and seeing our parents going through these stages, and thinking and hearing what they're wanting and actually what we might want. It sort of brings it up. I think we're less in denial and more able to perhaps face and start thinking about death. So it's the only times really, I haven't listened to many debates in Parliament, but actually listening to the assisted dying debates in both Scotland and in England, I've never really heard such emotionally charged debates. Where people are really talking about their parents' death, their own illnesses, their vulnerabilities, their partners. So I think there is something to think about, that we're all starting to think about this as part of life, perhaps.
I don't want to derail us from a conversation about assisted dying, but I suppose what I have noticed online is a lot of linking of assisted dying bills with also expansion of abortion laws to include abortions to full term, and whether, is there something going on, do you think, in terms of how we think about life generally?
Yeah, I can't speak to the abortion. No, it's not the area I've been thinking about, really, or been involved in talking about. But I think it would make sense what you're saying, that we're actually, what is life about? What's the meaning of life? And maybe a big part about the meaning of life is about the meaning of death as well, the end of it.
Yeah.
So I think maybe we are. And although there was a big global movement that was started before the pandemic, I do wonder whether there's also something about the pandemic and what that made us all face globally about death and life that might also be being played out in this discussion and this work as well.
How focused do you think your views and attitudes were to assisted dying before this bill became in motion?
I really don't think. Well, I was very focused on suicide,
Mm-hmm.
so that's been my focus. So thinking about death, certainly thinking about the end of life and death, but in a certain context. And it's interesting. I mean, I think a lot of us in mental health, and I'm going to say this about psychiatrists particularly, we spend our whole life thinking about death, really, and thinking, whether we like to admit it or not, we think about suicide all the time. So we're all the time thinking about death. I'm going to speak, very much for myself. So I think there's something about bringing that back out into the open, that is actually, maybe it's what a lot of us are thinking about, really, at the back of our minds,
I was thinking about this, Rachel, because it seemed to me that there are different kinds of conceptions or realizations of death. So there's the resistance to dying and the fear and terror that goes with it, which seems to be common in all creatures. And then there's the fear or the dread of loss. Losing, obviously, one's parents is one example you've just mentioned. But for me, it's the sadness at losing everything that I love and cherish so much. Do you think these two things are connected?
Very much. Yes, very much. What I was coming to mind, and I was trying to remember the name of the book, written by a rabbi who'd accompanied people, I think at least 1,000 people, to death, if you like. And I'm sure that the reflections that he was having, which was interesting, it was what I was associating to you when you were talking, was that for a lot of people, and my mum says this, that death can come as a friend in the end, but actually that the real difficulty is to do with the saying goodbye, and not just for the person who's dying. That what he noted was that sometimes people went and allowed themselves to die at the point where their loved ones had accepted that they were going, that somehow it was to do with the loved ones accepting the loss more than the person themselves. The person themselves could have accepted it quite a long time before, but it was to do with the loved ones having accepted the loss. So I think there's a lot around this. And I think this comes into certainly some of the work, and I've just been writing about this, about the confusion in the terminology we use. So in different countries, different terminologies used. And when we started talking about it in the UK, it was assisted dying / assisted suicide. And I think from my perspective, there's a huge difference between the concept, theoretically, if you like, between assisted dying and suicide. To me, they are different things. And of course, they'd be played out in real life with a lot of crossover. But the concept of assisted dying, to me, that I understand, and in talking to people who are involved in this, for example, in Canada, that it's about a good death. The idea that you have mourned the reality that you're going to die, that you have come to terms on some level. And it's about being able to say a considered and thoughtful goodbye and have a good ending. So you have mourned and you have come to terms with something and processed your losses around this. Whereas suicide, and so the bereaved, if you like, if we're thinking about assisted dying, hopefully, and certainly feedback from Canada seems to be there is evidence that that this is the case, that the bereaved can be left feeling in a quite a resolved state, feeling that they've had an opportunity to say goodbye, that this has been a good process for everybody. Whereas suicide is not about having mourned losses. It's not about having come to terms with the loss aspect of things. And it's more an acting out to prevent having to come to terms with loss, and the impact of suicide is that of a more destructive event on those bereaved. So I think there's a huge, when we put these terms together and we don't define them, this is my view, that actually this is a big problem because we're talking about two different things. And this, for me, is one of the problems with the bill as it stands, is I don't think there's any thinking around the difference. And for us as psychiatrists, particularly, in mental health, there's a whole move to prevent suicide. And then we've got a role in assisted dying. Well, how are we going to work out when we're assisting in suicide and when we're actually assisting in someone having a good ending, or when we're going to actually be assisting someone in a bad ending? How are we going to work out the difference, and how are we going to think about that?
As you were talking about sort of that getting to the point of resolution, it reminded me of, have you seen Grief Walker by which features the work of Stephen Jenkinson, who's a doctor who worked in, I think he's Canadian actually, Canadian or American, and worked in palliative care, and he kind of like covers the way that people need to be able to approach death and having conversations and reflecting and preparing for death, which all seems to go towards a good death. Previously, we interviewed Mike Grenville, who's a death doula, and he spoke about, the things that people need to have a good death. But when you think about wanting to have dignity in dying and not having a lot of pain, I think for me, that's when these discussions first started, that's what what's wrong with people wanting to have that kind of death and ending where you're not in a lot of pain, not suffering a lot of indignity, kind of when your physical health is ailing. But increasingly, I suppose we've seen stories from other parts of the world where, young people have been enabled to die, and quite often that seemed to be about a hopelessness within the system. So the system deciding that person's quality of life was no good, and because they'd got a history of abuse, therefore their life wasn't worth anything anymore. And I suppose that distinction that you're drawing about the difference between assisted suicide and assisted dying is so important, because I think my own personal opinions are quite different on those two different subjects.
Well, so we've been having discussions. I've been having discussions in different settings with people, and the discussions often start in quite a simple way. I was having one earlier today, actually, which is, are you a for or against? Oh, I'm for, I'm against. And we start those conversations in that way. But actually, the more we talk about it, the more something unravels into a much more complex situation, as you can see happening in both the bills in England and Scotland, that initially they come and the people go, yes, I'm really for this or I'm against it. And then as they start having the debates in Parliament, all the nuances and the complexities, because actually what we're talking about is something incredibly philosophically complicated. It's not a simple thing. And then the more you talk about it, the more confused you get. And the more you think, I really don't know what I feel about this and where I'm sitting on this. And, so I think what can sound like quite a simple discussion or a simple, and there's such a focus at the moment on having an opinion and choosing a side. As soon as you start to engage with it, it unravels fantastically to complexity. And this is an absolute case of that, really. I'm finding from my own perspective that my view depends on what identification I'm taking up in myself. So if I'm seeing myself as a non-clinician, as a person, and if I'm thinking about, if I talk to my mum's very clear about this for herself, she's 90, having the option, I think, would be reassuring. There's something about that might be reassuring. But if I'm sitting in my clinician role as a psychiatrist, in a different position, I'm thinking, hang on a second, there's a lot of complexity here. I'm not at all happy. It's not with the reality if this goes through or not, but actually we need to think about some more of the complexity, because what you see happening in Canada, for example, is a situation where I think the complexity of something hasn't been thought about, and things get acted out very powerfully in the way that you're talking about. There's lots, and how do you safeguard and really be thoughtful in a system where there are such powerful emotions at play, really? And I've written with a colleague, Joe O'Reilly, about the countertransference in assisted dying, which I don't think anybody's really thinking about. But if you're confronted by someone in a lot of distress, as a clinician, you might think, yes, oh gosh, yes, let's put, absolutely, I totally agree with you, without being able to sit back and think, well, actually, with some support and working through with mourning, something, things might change, opinions might change. So I don't think there's much real thinking about that process. How are we going to work out what's going on? How are we not going to be drawn into acting out ourselves? And I think in Canada, my view, looking at the data from Canada and talking to people in Canada, is this is what's happening to a degree in Canada. In Canada, you've got, there's two different things that just to touch on around that in what it looks like is in the countries where the death is facilitated by a physician. So the physician is active, if you like, the picture of euthanasia. That when people put themselves forward, they have a much higher completion rate than they do if it's self-administered, which is really interesting. And I think that so it nearly is 100% if you put yourself forward and a clinician is providing it. Yet if it's self-administered, I think your chance of going ahead with it is much less, so about 60 to 70%. When you think about that, that's a very powerful counter-transference type of situation. How likely are you to change your mind if someone's coming along saying, yes, you said yes, that's great, here I am, you're surrounded by your family, to be able to say, well, hang on a sec, do you know what? I'm feeling all right today. It's quite nice seeing my family. Maybe I'll put this off for tomorrow, or could you come back another time? Maybe it's very, very difficult.
Yeah, that's really interesting. I mean, just by the by, I haven't listened to many of the debates, but I've listened to some. And as you said, they're very powerful and very passionate. And what's striking is that they're much more authentic and real and genuine than virtually anything else we hear in our political discourse.
Absolutely, that's exactly what I thought. I thought, wow, this is about the most emotionally honest and emotionally powerful debate that I've heard, really. It is a very, very emotionally charged landscape, isn't it, really? Which is also part of the difficulty in having space to really sort of stop and think about what does this mean, and how are we going to take this forward if people want to take this forward.
And thinking is so important, isn't it? I mean, I've come across this in virtually all areas of work or activity that I've been in. It's just finding the possibility of carving out space to think and to talk about things.
Yeah, I mean, and I think personally, I found with this that thinking means having a lot of discourse with other people. That actually it's through the discourse with other people that you can hear the multitude of voices and hear all the different opinions and take that in. And that in a way is the antidote to opinions and division, isn't it, really? And to share, we've been from a situation where people are on one side and the other to all of us saying, gosh, we're all quite confused together actually about what's going on here, aren't we? So, and that's a sort of much healthier position, I think.
I've worked a lot in therapeutic communities in prisons where we spend a lot of time in large groups arguing about things. Of course, there's always the pressure to cut things back, to curtail discussion, and the real effort has to go in widening it out and keeping things going.
It is, but there is a reality to something, isn't there? And you can see it with this as well. And I, in the different therapeutic environments I've trained in and whatever, there can be there's something about the concept of thinking and space to think, which also can become distorted in a way of blocking things. Because, there is an emotional energy around this. Maybe there is a very important thing that we do. A decision does need to be made. Something does need to happen. And there is this question, well, how do we think in this process and not try and block something, but sort of say, well, look, we just need to have a bit of a think about this. And let's say it is going to go through, let's say it is, then how are we really going to, we've got a short window of opportunity. If we don't sit and think about how this is actually really going to play out, then we're going to miss that opportunity, and then things are going to be put in place in a rushed way because something will start happening.
So, Rachel, what's the attitude of the Royal College of Psychiatry towards the bill and towards this whole area, really?
So I'm very much talking today from my own perspective and not the Royal College's perspective, but just to say, I think the Royal College have put in quite a lot of thinking around this. And I think they've released, their view, which is they're neutral on the bill, as in assisted dying and the topic. But I think that they have concerns about, as it stands, the challenges this is going to pose in the way probably that I'm talking a bit about now. How are we actually going to really safeguard people? How are we going to work out whether someone is in a suicidal crisis, that with input and support that they will recover from and want to prolong their life? How are we going to really work out the difference in this situation between mental illness and normal grief and loss about facing a terminal diagnosis, and it's as though, certainly the way I'm thinking about it, it's difficult because something's being given to psychiatrists in this to just be able to give an answer to. And I don't think it's going to be an easy thing to work out. And I think in places like Canada, I don't think there is space for reflection. Something is getting very systematised, I think.
There's been a lot of comments about sort of the lack of access to good palliative care. And I wonder if the NHS was in a different position. We've seen a lot about how the NHS is creaking at the seams. If there was better quality palliative care available for more people, do you think that would make a difference to the discussion?
Well, I think that's certainly being discussed, and I certainly hear that being discussed. But then I suppose the question really is, in my mind, as we talk about it, again, everything sort of unravels into something more complex, is what are we meaning when we're talking about, what actually are we meaning when we talk about good palliative care?
Mm-hmm.
And what's going to be the difference between good palliative care and assisted dying? Is it? But undoubtedly, we need to think about the quality of the end of people's lives. I think that's the big, whatever the outcome of this, whether it makes it through Parliament or not, I think what we're all doing is actually thinking about the quality of the end of people's lives and how important that is. And I wonder whether, again, I was talking about the pandemic. I think that I'm going to call it is the big crime in the pandemic from my perspective, looking back on it. And it's very funny when you're in something, you can't make sense of something, but was people dying on their own?
Yeah.
Do you know what I mean? And I think that is a very, very painful thing for people to live with.
Yeah.
In a way, that's a terrible, that's a terrible, terrible sadness, isn't it? And I think this, I wonder whether something about that has made us all have to think about this, and that wasn't okay. What does make a good death, and and maybe there really is something very, very important about reparation and saying goodbye and having a good ending, if possible. And what does that really mean?
Such a good point, because I think we probably all saw those heartbreaking images of people kind of in homes having to talk to their loved ones through glass, which was just absolutely heartbreaking to watch.
Yes, or people saying goodbye on iPads,
Yeah.
And not being given the choice, if you like, to take the risk.
Yeah.
The loved ones might well have taken the risk, mightn't they?
Yeah.
To go and say goodbye in person. And it's, so I think it is heartbreaking. And, I can feel it in myself for talking about it now.
Yeah.
And the rest, other aspects of the pandemic, all sorts of things we could discuss. But that, for me, looking back on it, it was the biggest learning point from my perspective.
You've highlighted that, Rachel, but do you think we've really given it much thought as a society?
Well, I think maybe this is our way of giving it some thought. That the debate around this is really a way of giving it some thought, and that maybe if we're put in that situation again, there might be more capacity to resist that. From my perspective, a really, really big part of something is how the bereaved are left, not with regret, and that actually a good ending is very, very important for the bereaved. And I think also there is something very important, isn't it, about that maybe there is something really about that death is not, in a lot of cases, death can be welcomed. This is what my mum talks about, and I think I just mentioned it, that death can be a friend at a time, and that there maybe isn't, what she says is there's not really enough talking and thinking about death as a friend coming at the right time, or coming, and that we're all so panicky and unable to think about it and look at it, that makes it a much more frightening thing rather than a sort of a much more resolved part of life.
I was wondering as well about that sense of perhaps people's dislocation from spirituality as well playing a part. I don't think that necessarily needs to be tied to formal religion, but when you kind of like watch and listen to accounts of people who've had near-death experiences, they have a very different attitude towards dying, don't they, than other people. The sense of they were being welcomed and not really wanting to come back to life. I do wonder whether if we were more connected to our spirituality, whether death wouldn't feel so scary or final in a way that was more comfortable for people.
And I think this is a large part of the debate as well, isn't it? And I think quite a few people are thinking about the role of faith in death, and how having faith can make something a sort of smoother, more accepted. But yes, I think we're all trying to find something that perhaps works faith-wise for us in a less dogmatic environment.
Do you think? I was just thinking that my parents my parents died a long time ago, decades ago. But what really upsets me, what really makes me sad, is the fact that when our dog died 6 years ago, I was in Italy, and I felt terrible ever since then. Do you think sometimes we condense our grief over figures in our life and kind of reactivate the grief in some later stages?
Absolutely. That's supposed to be one of the big plus points about animals, I think. And one is that they're much more straightforward to help with mourning. That the grief is much more straightforward, and absolutely. I think there's quite a lot of thinking around that if you've had a complex relationship, and parental relationships are quite often complex, that grieving isn't necessarily the most straightforward thing. When you have a loss, like you lose your beloved animal, then absolutely all the grief that's been locked down or been put to one side can come out in a much more straightforward way. Certainly happened with my husband. When his father died, it was more complex, but when our dog died, it was a much more straightforward grief, and you could absolutely see that quite a lot of the grief towards the loss of his father was coming out in this way. Yeah, I mean, it's also supposed to be for with children as well, isn't it? To help, to try and face and lean into grief and mourning, because I'm sure you're aware of the whole nature of psychoanalysis and psychodynamic work is about trying to lean into grief and to try and mourn and not be frightened of it. And it's through that process that you actually grow. Your ego grows with resilience, and you grow a much more sort of resilient. I don't really like that word very much.
Yes. Do you think there's a difference between the way in which men and women grieve, or is that too much of a generalisation?
Well, I think in so much as, I mean, I was thinking about, that men die by suicide 3 times more than women, certainly in England and UK. And I think the same factors come into play, which is to do with men struggling with alexithymia more than women due to cultural issues, that men aren't helped and supported. I think it might be different within sort of the younger generations now, but certainly when I was growing up, men were not supported. There was the whole issue around toxic masculinity, wasn't there? That men were not supported to interpret, feel, engage with their emotional life. So didn't develop in the same way that women did, the language and capacity to symbolise their emotions. And that's thought to be one of the reasons why men die by suicide more than women. So I would extrapolate that and think that that's probably very true in all stages of life, really.
Do you think for staff that I'm thinking really of health staff in all settings, I guess. Do you think there's a difference in the way that they experience people who have killed themselves, committed suicide, and those who are seeking assisted dying? And is there a kind of difference in the way that we as a general public might view that too?
But I think that's, I think that, and again, I don't think there's any easy answers to this, because I've not been part of this in this country, if you see what I mean. I've not been involved in it in an active way, because the bill hasn't passed yet, so we haven't come up against this. But I think this is what we're sort of really trying to work with. How do we work with a paradox of suicide versus assisted dying? How we, and I think we are talking about 2 different things, but I'm not sure we've quite got to that in the discussion and debate as yet. But certainly this is the discussion and debate in many environments I'm in. Yeah, I think that's the. I don't know quite how we resolve this paradox as yet. I think it will probably come with time. In talking to Canadian people who have been involved in this, I think they see it very differently. This is sort of, but I do wonder whether something can be idealised in a way, that the idea, the concept of assisted dying can be idealised as, isn't it wonderful? It's just so lovely, which I'm not sure is the truth about it either, really.
And you're talking about the sort of the need for reflection and how complex this is, and yet is in some ways is being boiled down to something quite simplistic. But I think that just also makes me think about our attitudes in society to disabled people and people who are vulnerable generally. And I know there's been quite a lot of opposition to the bill from groups that represent disabled people, and I can understand why, because I do think we have quite a negative attitude towards disability and people who live with disability, don't we? So I think unless we can be open about our biases and prejudices, then it feels like we could be at risk of making some really bad decisions for people.
Absolutely.
And obviously doctors are going to be prone to those same biases as the general public.
Absolutely. So this is something that we've just been writing about, which is the concept of this sort of systemic or societal countertransference, which is, and Brian Mishara, who is a Canadian sort of clinician and ethicist, has written about this in Canada, that the concern about ableism, that actually, oh gosh, it must be so hard to live life as you are, and I can't imagine that I'd want to continue. So yes, off you go then,
Yes.
And that actually that these are probably very strong societal biases towards what is a well-lived life. You have to be fit, you have to be functioning in this type of way. So yes, I think that is a big area again of safeguarding concern, really. How are these biases? How are we going to be able to weed out our biases? I don't know. How are we?
I was just wondering, I was just thinking about the horrible weight for doctors, actually, because doctors are going to have to know where they stand in a way that other members of the population won't have to. And I just wondered what that's like as a doctor.
Well, this is another big area, again, this unraveling of thinking around this. So sitting in the role of a clinician and as a doctor, I think, I feel very concerned about what does this mean for the role of for doctors, that actually in Canada, doctors are going around and actively, providing MAID, if you like. Now, what does that actually do for people's perception of the medical profession, the professionals themselves? What's actually happening? What are they being drawn into providing role? What is the difference even between killing somebody and euthanasia? What's the difference? Is it just, some people are saying, well, it's about consent, but is it? I mean, I don't know. I haven't got any answers to these, but I think this is a really big question that, again, we need to engage with. If, as doctors, our role is to do no harm, where does this come in? What is our role? Is this our role? Maybe it is. Then how are we going to think about that and define that? And how are we going to train people for that?
I might be being naive in terms of I don't know the bill well enough to know what safeguards are there, but what's to prevent another Harold Shipman, for instance? He was killing older people who might have looked like they were all up for assisted dying. What safeguards would be in place? I'm not necessarily expecting you to have the answer to that,
but I mean, I think there is an important question there, which is how are you going to tell the difference? I mean, in Canada, you have a very small amount of clinicians who are providing MAID for quite large numbers of people. So what's being put in place to have a think about the impact on these clinicians and whether is that okay? At a certain point, do you need to stop? And, what's reasonable to provide? So I think, again, there is this whole question of what's the difference? How are we going to, they're very deep philosophical questions, really, aren't they? Certainly for medical professionals, of how are we going to conceptualize this? And I think it also comes into the debate about, is this a treatment or not? So is it a treatment? Again, something for everybody to think about. Could it be considered as a treatment? If so, how are we defining treatment?
Yeah. And I guess also, if it's only a small number of people volunteering to take those roles, actually that could be what you're doing a lot of the time, which could be very corrosive to your own sense of integrity and spirit, I guess. Over time, will there be an expectation that all doctors are willing to take on this responsibility to share the burden across the whole profession?
Well, exactly. In Canada, this is 7% of the people to death is by MAID now, apparently. This is just a sort of I think this is the recent figures. So this is this is really quite a big change in the nature of society and the role of medical professionals and the way we think about death. Mm.
That surely could be interpreted or could be understood as either an illustration of a great need
Mm-hmm.
or a catastrophic misuse of the legislation. How does one find out?
That is a very good question, isn't it? And once, if something, and I think Made in Canada is saving the government quite a lot of money, then how do you roll back from something? How do you put a pause in and say, hang on a second, just stop for a second. Let's just have a bit of a reflection about the impact here and how we're doing this. And do we need to put in other safeguards? And if you've, conducted 50 deaths in this way, maybe you need to pause for a little bit and have a break for 6 months. How do you put these safeguards in?
Do you have personal opinions about these matters, Rachel?
Well, I mean, I suppose I was thinking, if I'm not in my clinician role, I would personally, I think, and I would personally like to have the option. I think that doesn't mean I would use it, but I think I probably would, or I'd like to think there was. But when I'm in my clinician role, I feel differently. I feel very anxious. So, and there are probably other roles that I have in my head where I feel different things about it as well. These are just two that are most in discussion at the moment. So I certainly haven't resolved in myself the division that I feel about this. And my guess is that quite a lot of us feel divided when we stop and think about it.
Yeah, kind of your idea that you might want it as something for yourself kind of resonates. But I work with a lot of whistleblowers and so spend a lot of time thinking about corruption. And that side of me makes me feel really quite alarmed by passing something through where there doesn't appear to be enough attention to the nuance and how open, things that go wrong in society have often been introduced for good reason, but there hasn't been the safeguards against the more malevolent uses of them, and that I think is quite concerning.
I think there's also something about emotion, isn't there? That sometimes, and maybe it is the right time. There's something about a wave of feeling about this, and maybe it is the right time, if that's the case, for something to go through. Do you know what I mean? Maybe we're just at some point that we don't, we think too hard about it. It gets very confusing, but maybe we are at the point where something is just going through, and it's certainly gone through in quite a lot of other countries. So that's another part, which is just thinking, well, maybe it just needs to go through and then we'll understand something a bit more. And the more we think about it, the more confused we get, because it is actually a really difficult thing to think about. But maybe so I move from different position to different position of thinking, well, yes, no, maybe. Yes, no, maybe.
What are your thoughts, David?
Well, what's on my mind is what Rachel was telling us earlier about the difference in the rate of follow through if a death is provided, as it were, or if it's self-administered. I found that very worrying.
So certainly in the Scottish bill and in the England bill, there's no option for it to be provided in that way. It's self-administered, but still the nuance around that. Will a physician need to be present? Will a physician not need to be present? There's debates around that. So that's something I think to be. I find that to be reassuring in these bills.
Good. Well, that was terrific. Rachel, you come on very generously, give your time to us as an expert. What have you got that you're currently thinking about?
Well, I'll tell you what I'm thinking about at the moment. It's to do with scapegoating in mental health services. So I'm
very relevant to the suicide conversation.
Yeah, I'm very, very activated at the moment about something that I absolutely know is happening in mental health services, which is to do with scapegoating after serious eruptions of human destructiveness in suicide and homicide, and how easy it is for people to be identified as a scapegoat, and what a horrific position that really is, and how it doesn't help us think, and it certainly doesn't help people mourn. And we all know that unconsciously this is happening, and it makes it a very, very anxiety-provoking environment to work in. If you see this happening to your colleagues, you know equally that this can happen to you. So it's happening. I can see it happening in the newspapers a lot at the moment. The media have a very important role in whipping up these narratives of blame scapegoating, and it's a very primitive part of all of our natures, and we can cover it up with the concept of the word. I've become extremely interested in the way we use words, because I think we use words and they don't say that we don't use them in the way that they're meant, or they're paradoxical. So if you like, we use risk as a word that actually I think means suicide and homicide mostly, and we cover up the idea that we're talking about suicide and homicide with the words risk. Safety, another great word that's used all the time without any real definition. How can you keep someone safe from the contents of their own mind? Bring them into hospital to keep them safe. Don't think there's any evidence that does keep people safe, whatever safety means. And I think accountability is one of these words that it can sound reasonable. Someone needs to be held accountable. Oh yes, someone needs to be held accountable. But actually what we mean is blame. And we don't really care who is held accountable, blamed. Just need somebody. We need someone to be strung up after we've had this destructive event. I don't care. I want to see someone killed, and I want to see someone killed publicly, and that's what I want. So I'm very, very suspicious of the term accountability at the moment. So that's what I'm thinking about, and I'm writing about scapegoating at the moment.
Brilliant. We might get brave enough to ask you to come on again a third time to have a conversation about that. Thanks so much for your time today, Rachel. Another brilliant conversation.
Thank you very much.
Thanks a lot.